Africa. We are going to be discussing sexual health and reproductive rights in Africa, and we are going to be focusing on Kenya. My name is Kato Mukasa. I'm a lawyer by training, and I'm currently based in the UK. It's the summertime here, so that's why I'm putting on this lovely t-shirt. But I'm Ugandan and I'm proud African, and I'm happy to be having two important guests in our studio today. And of course, with my co-host Lynda Tilley, who is based in South Africa, who would like to welcome you. One is a medic, another is a policy analyst, and I'll be requesting you to join us and introduce yourself. I'll begin with the person in the blue shirt. Welcome.
Thank you very much.
Can you please give us a little bit of introduction about yourself, and then you can be able to hear from the other guest. Welcome.
Thank you very much. Am I clearly audible?
Yes, I can hear you very well.
Okay. My name is Morris, commonly known as Secular Kenya. I'm a Kenyan, and I'm a public policy researcher. I'm a humanist. I carry many titles. With regard to this topic, I'm very passionate about public policy, and especially with regard to social protections and as well as reproductive health or health in general. So yeah, I have a master's in public policy. I'm a member of Institute of Economic Affairs, Kenya, and I'm very glad to be on this show, and hope I can give my 2 cents on this topic. So thank you very much. I'm very honored.
Thank you so much, Secular Kenyan. I love the way you describe yourself. Thank you for being part of the show and doing the great work as a public policy researcher and analyst. We hear the introduction from the medic, Eugene. And welcome my co-host Lynda Tilley, a human rights advocate based in South Africa. Lynda, welcome.
Yeah.
Mr. Eugene.
Thank you very much. My name is Luchevereli Eugene. I am a medic. I am also a student. And yes.
We can hear you, sir. Continue.
Yes. As I've said, I am Luchevereli Eugene. I'm a student. And also, apart from that, I also identify as a secular humanist. That just as much as I can say. But I'm very much passionate about health, and when it comes to reproductive health as well. So also it's a pleasure to meet all of you, and also to have your thoughts and have a few takes on today's talk. I'm very much glad to join you guys. Yeah, thank you.
Thank you so much, Mr. Adrian. Thank you so much, Secular Kenyan. Secular Kenyan, I don't know whether you would like us to tell the viewers the other name apart from Secular Kenyan. People may want to find more about the Secular Kenyan. If you don't mind, if you want to tell us a little bit about the other name of you.
My name is Morris Washira. And is there more to that name? I think that's my normal name. Secular Kenya is just a name I use when I'm in the humanist and secular world.
Yes. Thank you so much, Mr. Washira. I'm very proud to hear you loving the Washira name. Lynda Tilley is my co-host. My producer is Brian Kabeko, who is your ally in Kenya. And of course, we have James Bongo in Uganda, and we have Logan in South Africa. That's the team we do work with. Lynda, you are the co-host here. Welcome. And we're discussing sexual health and reproductive rights in Africa with emphasis on Kenya. Lynda, your opening words on this.
Hi, good evening, everyone. Thanks for joining us tonight. It's great that we have two Kenyan guests in the house with us tonight to discuss the reproductive health in Kenya and in Africa, which is a very important topic. I think it's one that we don't talk about that often, and it's something that's very, very important to all of us in Africa. And we have so many people dying each year from mostly in labor, and so many children suffering. We have HIV positive teenagers, and people are really battling out there. So it's really great that we've been able to have you guys on the show with us tonight. Kato, we've got a problem with your audio. I don't know if you can still hear me, but the producers have just let me know if you could figure out your audio. I think it's your mic. I don't know if you guys in Kenya could hear Kato's sounded almost like he was talking underwater. So I think he's going to be sorting that out, and then he'll be back with us. So it's great to have you both on board tonight, and I know that you've both introduced yourselves already. I just think that we've got, this is a topic that we don't talk about that often. I was reading some of the United Nations reports earlier today just to bring myself up to speed with it. And according to the United Nations and the World Health Organization figures, Africa accounts for 1/10 of the world's population and 20% of global births, yet nearly half of the mothers who die during pregnancy and childbirth are in Africa, which is actually quite a shocking statistic. I believe that 1 in 26 women, there are maternal deaths in Africa, whereas for the rest of the world, it's 1 in 7,300 people. That is a huge, huge, huge difference, which shows that something is seriously off balance here. I just think that I know Kenya very well. I've lived in Tanzania most of my adult life, and I know that Kenya is very, very advanced as an African country with lots of very highly effective people, and your medical services are known. I know for us in other parts of Africa, in East Africa, that if ever we have huge medical issues, or even myself with my own pregnancies, we went to Kenya for treatment, to go and see doctors and obstetricians and that, because you guys are renowned for your medical care. I know, look, all our government hospitals in Africa are pretty, short on equipment and things like that. We battle a lot, but Kenya is not as bad as some of them. And I must say that through my pregnancies and afterwards, I had excellent medical care in Kenya. I was once in a life or death situation where I was actually saved by Kenyan doctors and surgeons. So I think that it's amazing, and I just, with so many people and your services there, and capable people that are capable of carrying out these services, I just wonder why are we battling so much in Africa, and especially in a country like Kenya, which to us on the outside is very much a forward-thinking, modernized country with lots of effective people and highly educated people, especially in your medical profession. So I'm just really interested to know, a question for the whole of Africa is why we are battling so much with this issue.
Yeah.
Are you back, Kato?
I'm back. I had to switch the gadgets. I'm back, and thank you so much. I was hearing you. Can you hear me?
Yes, we can.
Yes.
You don't sound like you're underwater anymore.
Thank you so much. Technology. Wachila, Mr. Wachila, we start with you to talk about Kenya, of course, talk about what's obtaining there as a policy researcher. We are aware you have some figures. May you please tell the viewers the statistics in terms of infections, in terms of abortion crises, in terms of access to reproductive health care in Kenya. How is it in Kenya when you talk about sexual health and reproductive rights?
Thank you very much again. To start off with Africa, I think maybe to start with her question, the biggest problem the African countries are facing is, okay, in terms of healthcare, is number one is finance, cost, and number two is lack of political goodwill. in case of Kenya, lack of political goodwill encompasses a lot of things, including corruption, including the political systems. So in Africa at large, that is the main problem. But in Kenya particularly, I think the bigger problem we have is lack of political goodwill or lack of political accountability. Because I think one of our NHIF, which is the National Health Security Insurance Scheme, it has more than enough resources to be able to cope with some of these small challenges. But because of corruption, because of mismanagement, because of and corruption is both private and public, because there is a lot of private sector interest in terms of healthcare. So these ones are also tend to push for the problem. Now, to come to Kat's question, the figures are not looking very good. I think Kenya, in terms of healthcare, despite being advanced, we are ranked over, I think, about 111 in the world. So we are not looking very good in terms of be able to provide our healthcare. And hearing people say we are one of the best in Africa, then it makes me worried that what is happening in other countries. Because from where I started, I think I thought we are we are not doing very well in statistics. And this you can see, you can look at it from the things like our STI infections. We are currently ranked 44th, especially when it comes to STD like HIV. We have things like HIV. Though we have done a very good battle with HIV, we brought it down to 3.46 in last year. But still, this is mostly due to international finance, international support. Without international, the local capacity is still very at its bare minimum. So I wanted to specifically, I think, in terms of STI and abortions, the main battle we have is HIV. Of course, HPV is still the most dominant. HPV is still the most dominant STI, but HIV is still the most deadly in terms of death, in terms of the way it affects the household. And in 2019, we had around 40,000 new infections, and you can see that's not a good, and almost 20,000 plus deaths in this country, and these are most of them are preventable because as you know, HIV is you die from not from the HIV itself, for the virus, but from the other opportunistic infections. I can pause there, and then maybe we can look at the abortion statistics maybe in a minute.
Quite interesting so far from what I've discussed with the audience. That is a lot of work ahead of us. Please continue, Mr. Wachira, as we try to have the medic on board.
Okay. On unwanted pregnancies and abortions, according to the Kenya Demographic Health Survey in 2014, 34% of pregnancies in Kenya as of 2014, 34% were unwanted. That figure rose up to 41% in 2020. And what do we get that from that? This is an indication of the two things here I would like to see. There's the policy aspect, and the policy aspect is financed by is affected by the finances and the political goodwill. But then there is the cultural aspect of it, or the religious aspect of it. It's very big in this country, where we have situations where there's a lot of oppositions especially to abortion. There's a lot of opposition to access to contraceptives.
Okay, we seem
there's a lot
to have lost connection there with Qatar and with Kenya. We lost connection,
Sorry,
I think, but we're back now. Sorry.
Yeah,
I can see you, and I can hear Wachira.
Okay, great. I think it must just be my side.
Okay.
Michelle, please.
Yeah. So so I was saying those there's the financial, the policy aspect to those data, why the rate of unwanted pregnancies have increased to 49%. But the biggest aspect of it, the other side of it, is the religious, or the what I call the superstitions, or where the religious community has really pushed back on rights like access to contraception, access to abortion services, access to contraceptive like condoms and all these things. So as much as we have the financial problem and the public political problem, we have a cultural problem, which in this area is very pronounced. It's very visible. I wanted to talk about the Kenya, the National Reproductive Health Policy Kenya. We have a document, we have a policy in Kenya that is supposed to run from last year. It's supposed to run from 2022 up to 2032. And it has some interesting aspects. I don't know how much time I have for this so that I can plan it for the first minute.
Give us, we are thinking mostly on that. More 3 minutes can be enough, please.
Sorry?
More 3 minutes will be enough, I think, for you to wrap up, and then we go to another,
Okay.
to the doctor.
During the National Council for the Population and Development National Dialogue, so the Ministry of Health revealed that between January and 2021 and February 2022, they had about 45,700 cases of pregnant adolescents aged between 10 and 19 years. They also revealed that there are about 2,196 cases of sexual GBV cases, and about 12 to 9. These were people aged between 12 and 19. And it's also revealed that about 98 girls aged between 10 and 19 acquire HIV every week. Now, with those statistics, you'd expect that there will be a change in attitude or perception or a goodwill to tackle this problem. But let me give you just in a very nutshell what the policy talks about. The new, it's called the new National Reproductive Health Policy 2022-2032. It was launched last year at the States, and it has received a lot of criticism. One of the things you'll notice, the policy, I must say the policy is not the law, but it complements all other government policies. It's the key source of reference. For the reproductive health is the main source of reference. So there was a lot of engagement with the civil societies to come up with the policy, and then they came up with what they recognized the triple threat, which was adolescence, pregnancy, GBV, gender-based violence, and the raising rates of HIV, especially among young women and adolescents. But weirdly, instead of upholding sexual reproductive health and rights of adolescents, girls, and young women, and facilitating the access to reproductive health services and commodities, that policy determined that people attain full cognitive competence on matters of sexuality and reproduction at the age of 21. And it prioritizes one, abstinence and delayed sexual debut for persons yet to attain full cognitive competence. Number two, weirdly, it introduces a new requirement for enforced parental consent for reproductive health services. Number three, the policy also fails to adequately address critical issues such as teenage pregnancy, high maternal mortality rate from unsafe abortions. There's also a contradiction where the policy talks about mainstreaming special reproductive health data to people with disability, the elderly, and minorities. But loudly, it does not promote, it keeps quiet on mainstreaming of reproductive health for young girls and women, people living with HIV, LGBT, commercial sex workers, people who use drugs. It is very silent on all those. Finally, The policy provides for adequate age-appropriate reproductive health information on awareness for all persons, including adolescents and young people, which leaves the concept of comprehensive sexual education open to the definition. It's not very clear on what is this reproductive health, what is not reproductive health. So it leaves a huge room for the health workers to reinterpret and to interpret what they mean by these health workers. And considering services like abortions are illegal in Kenya, at least in paper, and considering that Kenya is a very conservative country, it's not a very good direction. It's not a very good policy direction for the people, especially for those who actually need those services. I'll pause there, and then I'll come and we can discuss the issue of unwanted pregnancies.
Thank you so much, Mr. Wachira. You can imagine, Lynda, what's happening in Kenya. It's quite frustrating. The statistics you have given us are quite disheartening. I'd say I attended abortion conference in Africa, which happened in Ethiopia in 2017. And the figures we got from Kenya, from Uganda, from the rest of Africa were worrying about abortion crises, about children, I call them children, teenagers who die through backstreet abortion. And I want to go back to the medical doctor. The practicing part of it, Mr. Eugene, how does it affect the medical fraternity when you see many young people dying because they are doing backstreet abortion? And how does the law affect you as medical doctors when you carry out these abortions? May you please give us a picture from a medical point of view, your concerns, and if anything you have done as medics to solve or to handle the challenges that come with abortion. Dr. Eugene.
Yes, thank you very much. With regards to abortion, I think what really contributes to it still being a nasty issue, it's number one, I think it's the policies that we have in place. Right now, yes, Kenya is one of the few countries in Africa, or we can say most of the countries in Africa that allow abortion only for specific purposes. For example, if it's if it's saving the mother's life, which is in danger at the time of the pregnancy. But that said, it doesn't really paint a clear picture on all the rights preserved in that. The Constitution in itself, it is followed by what it says. So any other thing apart from what the Constitution says, it will be taken as illegal. So the fact that most of abortion is, I think, illegalized, it sort of creates an opportunity for the unsafe abortions to go on, because some studies have actually been done, and they have actually showed that part of the reason why most women in Kenya and East Africa in general go for the unsafe abortions is, number one, because of the stigma associated with abortion itself, the societal stigma, and number two, it's because of the harsh punishments that are there imposed on those who are attempting illegal abortions or unsafe abortions. So this sort of creates an opportunity for rampant unsafe abortions, because there is also the economic factor. Quacks will want to make a lot of money from them. People want to take advantage. So it puts women largely at a very bad side of things. So I think how we ought to go about it is just to put in place good policies, better policies that at least tend to support most of the cases involved. Yeah, so that's what I can say about abortion in itself in Kenya. On the bigger picture, on an African picture, I think I only have a few statistics about it. We aren't really at a good place, because I saw that 97% of all abortions in Africa that go on in Africa are actually unsafe abortions. And some of the complications that the unsafe abortions lead to, we have infections, we have hemorrhages. All of this will contribute to the maternal mortality. And in Kenya itself, I think abortion is still one of the top contributors of maternal mortality. and even the post-abortal complications in itself. So it's actually a very hot topic. It's a very nasty topic, as I'd say, in quotes. But yes, things are not really good, but we can change on that. I think we can actually do something about it. Yeah, thank you.
Doctor, before I go to Lynda Tilley, my co-host, what would happen? What is the punishment for a doctor who engages in illegal abortion? Because the law in Uganda is quite different. Of course, as you said, just like in Uganda, the only exception to do abortion in Uganda and in Kenya now is when the mother's life is in danger. But we do know that there are quack doctors, there are traditionalists, there are backstreet doctors, so-called health experts who do these abortions. What would happen if a medical doctor was caught in the process of doing an abortion, which is illegal?
Yes, that's a very good question. Number one, if any healthcare practitioner is considered or is suspected to have engaged in an unsafe abortion or an illegal abortion, number one, their license will be stripped away, and then legal processes will also follow. It will be treated as actually murder. So you may think of a situation where lawsuits are being activated. So they may face very tough consequences of doing so. So yeah, that's still part of them. So in actual sense, apart from losing their license, they may also risk a jail term. Yeah.
Quite disheartening. Lynda, your analysis on the from the
Yes, well, if you look, sorry, my network's not great tonight. If you look at it just from hearing the statistics and from hearing from people who are, from the two of you who actually are, involved with this in Kenya, and I know I speak for Africa, is that you can see how much corruption plays a part in every single aspect of African life, from everything from education to medical care. It's all about, our national budgets in each country as well. Very little is often given to the healthcare industry. And I'm speaking from my experience of having known the Kenyan, having made use of the Kenyan medical facilities for about 13, 14 years. It's certainly not due to a lack of skill on behalf of staff, or not having qualified staff, or having resources available. It's just, that's why I asked the question, and I can completely understand how you say with the corruption and everything, because there is a high standard of skilled doctor care, surgeons, doctors, gynecologists, pediatricians. Really, I can say that. So it's not as if the people aren't skilled, or if there aren't hospitals and facilities. Kenya really does have it all, and it's very sad to see a country like Kenya that is sort of stagnant on this whole health issue, because it should be leading the way. And as you said, if you can imagine how bad it is in other countries where the healthcare is almost non-existent. It's very sad to see. And with the most, a woman, I think, probably see doctors and have more medical care throughout their lives than men, possibly, because reproductive health, and also with pregnancies, and with the whole thing with having children, and normally we have a woman will go to be treated for STDs or for infertility, or it's constantly, you are always, and as a mother, you are taking your children to the doctor, or you take your children when they're little for vaccinations and being weighed and that kind of thing. So the fact that women, I don't know if it's correct to say that women probably make more use of health services than men do, but the fact that it is failing women so greatly is very sad, because so many of these things are preventable. Like you talk about the STDs, HIV. I know cervical cancer is another big one that's been brought to light in recent years. I know in South Africa they've tried to implement a government program of having the girls actually vaccinated at school from very young ages to try and prevent this. And we find, I think with lots of things, we have these big drives where everyone is, awareness is raised for things like HIV, cervical cancer across Africa, AIDS Day and all that. And then it kind of fizzles after a while. And people tend to forget that health is a constant thing that we should always be working on and be made aware of. And I can completely see how the religion is also stunting this. If you've got a religious government, then you've got even more of a problem on your hands, which we all have got, because there is the whole stigma, like you said, Kato, about abortion and about contraception, even in many of the different aspects, different churches. Some believe, like I know the Catholic Church, in the past at least. I mean, I haven't been to church for years, so I wouldn't know, but are very strict on not having contraception, that you shouldn't try and limit your number. And I also see from the figures that I was looking at today that, as usual, it's affecting the people in the most poverty-stricken areas that have the least, in your rural outlying areas where people are not doing well. It's the young children, it's the child brides, I know there's a huge issue with fistulas, with young girls that are giving birth and their bodies aren't capable of that. Intervention, where perhaps cesarean sections should be performed and they aren't. And just the general superstition or stigma which surrounds anything that's considered ungodly or not what the Bible. And it's just so sad to see, because we're going backwards and not forwards in aspects like this. We should be streaming ahead, but we're not. And it's also a known fact that teenagers around the world have got so much more support than teenagers in Africa for exactly the same things, which again, we have to ask ourselves, why? And there's an imbalance there. And this is very unfair as well. So it's a very interesting topic, and it's one that we're all kind of aware of, but we never really look, well, no, I don't, never look into it in great depth, or actually talk about it, or do campaigns about it, or raise awareness for it. And it's just something that affects each and every single one of us, male, female, whatever age. It is affecting us all.
Thank you, Lynda. Going back to Mr. Wachila, the policy researcher and analyst, looking at the STI, sexual transmitted diseases in Kenya, I'm sure you have the statistics. Looking at the HIV prevalence, looking at teenager pregnancy crisis, I've been seeing the figures shared on the screen that infections are going high, abortions are also rising. When you look from the policy, from the what's being done by government, how much is awareness when it comes to use of family planning methods in Kenya? When you look at the condoms and other means of stopping these infections, means of avoiding unwanted pregnancies, your schools in Kenya allowing sexual health, sexual education being taught to young people. In terms of policy, what is there to stop this kind of trend where we have more young mothers than responsible mothers? What's there in terms of policy in Kenya in particular?
Now, let me complement, before I come to the question, let me complement what Medical leader have said in terms of the policy, in terms of where we are in terms of abortion in Kenya. There have been several attempts to legalize abortion. The secular community in Kenya is a minority, but it's also very vibrant, and it permeates all sectors of from the judiciary, from the government. So there have been several attempts to legalize abortion in Kenya. Because first of all, the constitution is not very clear. The constitution and the law are in contradiction, because we have a very new constitution also, which was promulgated in 2010. So abortion in Kenya remains restricted though, but there is evidence of high and safer abortions, and lack of clear guidelines on the provision of safe legal abortions. And post-abortion care complicates access to post-abortion care in health facilities. So as the medic said, unsafe abortion is still a leading cause of maternal death, especially not in Kenya, but also in sub-Saharan Africa. So there was a bill that was taken to Senate. It was introduced from Senate by a lady called Susan Kihika, who is now currently the governor of Nakuru. And it was called the Reproductive Health Bill. And it was very comprehensive in all these issues we are discussing, whether it's the contraceptives, whether it's abortions, whether it's post-abortion care. It was very comprehensive. It's called the Reproductive Health Care Bill 2019. But the religious associations are the one who lobbied the parliament, actually the Senate, not the parliament, to kill it. And the argument, of course, is the conservative argument. You know, these people are trying, they were saying, these people are trying to quote unquote legalize abortion from back door. So the state rejected it. Yes? Are we together?
Yeah, we are together. I can hear you.
Can hear you.
Okay. Okay. And then the ministry, of course, rejected that one because of the pressure from the religious community. And the loophole they say that this is a loophole for termination of pregnancies as a method of family planning. And also in Kenya, as medic will confirm, even when the wife, not every medic can carry out abortion. You have to be at a certain level. You have to be a certain level of medic. Not every healthcare profession, like a nurse, can prescribe her, even when the mother's life is in danger. So interestingly, in 2020, after this battle, there was a High Court ruling in Malindi, which is the coast of Kenya. And this High Court ruling, it affirmed that women's access to safe abortion is a human right, as enshrined in our country's constitution, and directed the parliament to enact law in this regard. The judge, who was called Nyakudi, when he made the ruling last year, there was this case involving a 16-year-old who had miscarried. And the 16-year-old girl and the nurse who had prescribed or carried out the abortion were both being taken to court. And this is the ruling for this court. They had been accused of carrying out abortion. So the ruling was very important. As much as the parliament is yet to enact that law, the thing that made the best thing that came from that ruling was the argument that police or the detectives cannot use you seeking medical services like for abortion. That cannot be used to arrest you. It cannot be used as evidence in court. So because what will happen is people are afraid of going to seek these health services. So and what will happen is because the medic is afraid of being in conflict with the law, so they would, if they to guard themselves, they are going to report this matter to the police, and that's where the problem comes in. So the one of the ruling, or the president that ruling has said, and there is no appeal to, as far as I know, is that you cannot use someone's access to attempt to access healthcare as a basis to prosecute them. But the parliament is yet to enact that law. And of course, there's a contradiction also with the Kenyan Constitution and the Penal Code, because according to Article 26 of Kenyan Constitution, the 2010 one, abortion is prohibited unless, in the opinion of a trained healthcare profession, there's a need for emergency treatment, or the life or health of the mother is in danger, or is permitted by other written law. So the other written law is now where it places the whole burden of this thing in the hands of the parliament. But the Sexual Offences Act allow women and girls who are foreign pregnant as a result of rape to have abortions. But there is an outdated Penal Code of 1963. And this one is the one that it says that it outlaws all form of abortion, including the one that is allowed by the Constitution. So there's that conflict. So the Constitution affirms the right also to life, which is what every conservative in Kenya has been using to argue that against abortion, against all these contraceptives. It affirms the right to life, but they have been misinterpreting that to say, of course, the way the conservative Republican argue, life starts at conception. So that's the argument they have been advancing. But now, access to contraception and pill. So condoms in Kenya are quite accessible, and they are free. About 80%, 84% of the condoms used in Kenya are free. They are provided by government, and of course funded by some international choir. I don't have statistics to female condoms. These are male condoms. I have no statistics to female, so they are hard to find. Maybe they are rarely used. But the ones provided by government, they are quite prevalent, and they are quite available in every entertainment joints. And also the bill, one of the other reason that was the bill that went to Senate died. It has not died actually. What the members did, they actually refused to vote for it because there is a contradiction. This, if the parliament was to vote in silence, the bill would pass. But because of the pressure from the conservative constituencies, no MP would risk being seen voting for such a bill. So one of the other things that that bill was providing for was provision of contraceptives to teenagers, especially in high schools. And that is also one of the reasons that they used to deny it, to bail it. The other thing I would like to say with regard to this, the final thing is there's the attitude. Of course, we have discussed this, the attitude of people when it comes to these family planning options. There's a lot of myth. First of all, especially among the unmarried, is this association with promiscuity. The parents would not, the idea that your teenage is using contraceptive would be, it's more of religious argument than an objective argument as to the problem you are trying to prevent. It's more to others. So there's that association, and also that one now leads to people exaggerating the side effects, exaggerating the whatever. You could even have a small problem, a normal disease, and they would try and link it to that. It's like a maid. Maybe you had this contraceptive. So there is that, and that one has really pushed people. Even the people who are married and should legally be using this thing, contraceptive, from sitting back and using them. Yeah, but the new there's a new survey that showed that use of family planning in Kenya has actually increased. We are currently studying at 61. That was actually as 2020, and this is has increased from 56% in 2018. Sorry. So it's a positive trend, but there's a lot of pushback from the conservative side. Actually, as Lynda has said, it's actually it's less of a financial and economic issue and more of a secular and religious and myth issue. Yeah, especially in Kenya. Thank you. I don't think we can hear you.
Kata, your sound is, I think your mic is off.
I'd put it off, to avoid the interruptions. Hope you can hear me now. Mr. Oshira, thank you so much. It was very, very important you gave in that submission, of course, about the case. As a lawyer from the legal perspective, I was very impressed that you have such kind of case on your shelves, and which is very, 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 very influential as far as abortion cases are concerned. Now, going back to the medical doctor, I understand this must be very challenging for the medical profession, where people still have negative attitudes towards some family planning practices. Of course, I understand from the policy analyst, Mr. Wachira, that religion and of course some cultural traditions are against some of these family planning methods. Now, from the medical point of view, how easy is it to sell family practicing methods to women in Kenya, for example? How easy is it to sell them to male clients when they come to you? And then you talk about family planning as a doctor talking to these people. How easy, how difficult is it from a medical point of view when you have cases of women, of young girls facing post-abortion challenges? How it's such a burden as doctors? How has it affected you handling these cases? I want you to walk us through what doctors go through from your practical point of view in a world, in a country where people have these biases, where the law is not so clear on abortion. How does it affect your profession? Your day-to-day work as a doctor in Kenya?
Thank you very much. Yeah, on how it actually affects the life of any healthcare practitioner, not just doctors. I think it can take a psychological toll, because when you come to realize that most of the unsafe abortions or the consequences of it are, some of the time or more often than not, is often due to lack of education or ignorance of the same. So there's an issue of awareness. There's lack of awareness on, especially on sex education among the teenagers. From the statistics that we have, it actually says that, for example, in Kenya, we have a contraceptive prevalence of at least 53%. That's really low. That's low. That's very low. So, and one of the reasons as to why it's really low, it's because of we have ignorance. We have other factors at play, but also ignorance. There's ignorance. So when you have a client or a patient wanting, for example, advice or anything about family planning, we actually understand where they are actually coming from, and so we take them from in a step-to-step manner to make them understand the health benefits of, for example, if it's family spacing and all that, and also the side effects that each of the contraceptive modes have. So we first of all have to make them informed. We give them information so that they can be able to make a conscious judgment on which contraceptive plan actually works for them. But that's really still not enough. I think the government ought to play a bigger role in that. It should also help in creating mass awareness on the same. The issue of sexual education, though it's a bit of a debate right now in the country, because some of the arguments against it is that, you know, if I'm a parent, what age is appropriate so that you can start to tell my kid the right choices based on their sexual health. So it's actually something that needs to include them. It's a national dialogue issue, but I don't think it has been done yet. So it's still a challenge in a nutshell. It's a very big challenge. But the moment we address the ignorance bit, we raise awareness, I think people will have the power to go about it quite easily. But right now, I don't think so. Yeah.
Doctor, thank you so much. I should tell you, Lynda knows that personally, I was born in a hospital setting because my mother for over 40 years was a nurse. So I ended up calling everyone in the medical world doctors and all, but my mother was just a medical nurse. And I should say this, I have much respect for medics because they make our lives tick. They make us lots of respect and admiration for the work you guys do. The guys like Wachira doing medical research and all this, massive respect. Now, going back to you, Doctor, as we prepare to go back to Wachira, when you look at Uganda, where I come from, there is a crisis where men don't participate so much when it comes to health awareness. In fact, I was following a TV program in the UK, and it was the same crisis where men tend to not so much participate in maternal health issues. They don't normally accompany their wives to hospitals. They don't normally want to do checkups. And when it comes to family planning, they leave it to women. Now, from a medical point of view, as a practitioner, how particularly from a Kenyan point of view, are men when it comes to reproductive health matters, or are they simply leaving women so that they can be able to figure it out, how they can prevent pregnancies and all that? When it comes to infections, STI, how better are men? Because you may treat a woman, and when a man is not treated, you haven't solved the problem. So we would like to hear from you as a practitioner, as a person in the medical world, how participative are men when it comes to health in Kenya? And how does it affect the medical profession, the hospitals, the clinics?
Thank you very much again. Yes, that's actually a common observance. It also happens in Kenya here as well. The matters on reproductive health, even the health-seeking behavior of all, women tend to have better health-seeking behaviors than men. You know, statistically speaking, even the studies have really shown that men are really reluctant. They only go for it when mostly pain is involved or it's really critical. But if it's on the baseline, it's not really their problem. I think that's a cultural mindset that men, mostly African, I can say Kenyan, East African men have in common. So the same thing can also be suggested towards the issue of, for example, fertility issues. You know, when there's an average African couple, an average Kenyan couple, and then they aren't conceiving, you know, before the man says it's him, it's most of the time it's usually the lady. That's how it goes. But evidence we have right now, it could be both, and sometimes it's even the man who's responsible for the infertility that goes on. So I think apart from it being a cultural bit, I think men, we should encourage each other to have better health-seeking behaviors. You know, when you're going for the reproductive health clinics, include your partner as well. It should be an all-inclusive. Even most of the advices we give in the reproductive health department, most often than not, it's usually given as a couple. You know, when your client has a partner, you just give them, unless it's really, for example, the more confidential issues that you don't reveal. But when it's all matters concerning reproductive health, fertility, and stuff, you should include the couple as a whole, so that you can really better their health-seeking behavior, so that one party doesn't really stay back when the other one goes. The same thing can also be seen to be taking place, for example, if it's an STI issue. You know, an STI, most often than not, the man will only come to report it when pain is involved. But when it's not painful, it's not really an issue. I can't really disclose it, you know. But for the ladies, it's really a bit different. You know, if it's something going on, they must seek healthcare advice. So the disparity is there. It exists. I acknowledge that. It's been observed. Yeah, but I think we can change on it. Yeah, thank you.
Thank you so much, Doctor. Thank you so much, Eugene, for that submission. Lynda, as a lady, as a human rights advocate, as an African who has traveled in several African countries, Lynda, I know you have a lot of information on this. What's your take when it comes to reproductive health? Now that you're in South Africa, what's there in Zimbabwe? You have been in Tanzania and in Kenya. What's your general observation when it comes to matters of health in Africa?
I would say a general observation, even nowadays, like you say, it's very much a female's reproductive health and things like contraception and childbirth, prenatal checkups and that. It's very much culturally seen as not a man's domain. You know, it's the woman get on with it, it's the woman with our mothers and grandmothers, and it's always been very much a woman's thing. It's very only in recent years do you really find even men being present during the birth of a child and things like that. So I think that is very much a cultural aspect of it as well. And women do seem to take more responsibility for things like women will go and seek contraception if they have access to it, if there's no stigma around it, and they will be the ones that will go and seek treatment for STIs and that before men will go. I just find that is pretty much a common thing. I also think that, and I'm sure that many women will agree with me, it's quite insulting when the statistics and that come out, and one of the excuses used for not wanting to make contraception so widely available is that if we have lots of contraception available at our fingertips and for young girls and teenagers, it will make us as women more promiscuous. I think being promiscuous or not is very much down to the person, the circumstances, and who you are. You're not going to become a promiscuous person or not be one just because you have contraception available at your fingertips. So I think that is also something that we need to get out with. The people that are trying to come up against that always say, we don't want our girls and women to have, teens to have access to this, because they will then become sexually active at a younger age and have many sexual partners or whatever, which it's down to personality, and it's not down to the fact that taking a contraceptive pill or having an injection means that you can just go crazy. It doesn't work like that, and I'm sure that most women will agree with me. The other thing as well, which I as a woman find insulting, that we must also try and get rid of, is the fact that they don't want to make abortions readily available, because then that means that people will be using it as a form of birth control, which is ridiculous, because any woman going through an abortion, no woman wants to put herself through something like that willingly. And you know, we're not stupid, and we are aware that we need to take care of our bodies, especially of childbearing age, where you have other children or you want to have other children in the future. I think it's very short-sighted of some of these people that are putting bans in place and that are not open to introducing new laws, to say to us as women that we don't want to make abortion readily available to you, because then you're just going to use that as a form of contraception. No woman is going to want to put herself through an abortion every time she falls pregnant after having sex. It's just, so I think these kind of things as well are being misinterpreted. You know, I feel sorry for Kenya, because I've noticed with your new government, there seems to be an increase in everything religion. Religion is creeping into aspects of Kenyan life that it never was before. It was always there, but now it's like in your face. And it's very, very sad to see a country as advanced as Kenya, with such potential in its people, to be pressed down again with this terrible religious aspect, the superstition of religion, because it's really oppressing people, and it's actually costing lives. Because if you have someone or a government that refuses to put things into place that are going to help women save their lives, like readily available contraception, easy access, you know, putting a lot of money in your national budgets into healthcare and that, and allowing people to have abortions if they want them and for it not to be illegal. At the end of the day, it's religion that's guiding them against making the correct decision for women in their country. So you could actually say that in this instance, when it comes to reproductive health and abortions and that, is that religious beliefs are actually killing women in Africa, because of this belief that people have. That's, no one really should have, like you say, it is a human right. We as women should be allowed to choose what we do with our bodies, and you know, whether to space our children or to hold off having children for a while to protect ourselves from disease and that. And it's just very sad to see that it's almost like we're going backwards in time instead of forwards. And I also just wanted to ask a question of our medic, our doctor, is that I know that they say that abortions are only allowed in Kenya now if the mother's life is in danger, or the baby's life is in danger, and you have to have a skilled person to approve that, a skilled medical professional. But now the thing comes in here, because you know how things work in Africa. They will determine who a skilled person is. So if it's a life and death situation and you have to make a decision on the spot to perform an abortion, what happens if the person that's there to advise you is not as skilled? The government will say, oh no, but by skilled, we don't mean a gynecologist, we mean a surgeon or something. That was the one loophole that I thought that might be used. And also with rape, I see that it is allowed in the case of rape, you are allowed to perform an abortion. But then who defines rape? A girl, many people don't report rape. Many people, there's a lot of awful things going on, as we know, where perhaps a girl is raped by her own father, or she's raped by her husband, because marital rape does occur. Who then gets to determine what is rape and what isn't? In order for you to perform an abortion on someone who has been raped, does that mean that that person has to have taken that case up and a person has been convicted in a court of law for rape? Or can it be a person who has been raped by a father or a brother or something like that? How does that work? That's what my question was. Because if you can only perform abortions on people who someone has been convicted and tried and sentenced for rape, it's basically not allowing it, because so many people are not going to even be able to. It's a case of, they'll say it's a case of my word against his. I was raped by my father or my brother or by somebody that I'm not in a relationship with. It's a case of the woman's word against, and I think that most women would rather just not do anything about it. So that's the other concern that I have, is how do you determine who determines rape? And
Lynda, you are really. I'm going to throw it back to Washila and the doctor, being secular people, being people who think outside the realms of religion and cultural practice. Oh, I do throw this back to you as we conclude. Lynda, I should tell you this. In Uganda, and as the doctor did say, as the police analyst did say in our conversation today, in Uganda, you have only one exception to abortion. That is, you are an adult and your pregnancy is either going to cause, actually is a threat to your survival. This is when you're allowed to do abortion. One, you are an adult, and you will assume you are married, and then the baby inside you, the medical doctor has proven that if you continue having this baby, you are going to be in a health problem. Now, there is no room for rape. There is no room for incest. We're talking about Lynda. Nothing. It means that if I forced myself on my daughter, I have 3 daughters. If I became mad and I forced myself on one of my girls, she must have a baby for me, the father, because the law is silent on that. So the law doesn't talk about defilement, doesn't talk about rape, incest. It is only giving you one exception. And this, I think I picked correctly. Mr. Washila and the doctor talking about this. This is what I know in Uganda. Now, we have only one exception. I don't know about South Africa, but what I know is that Ethiopia legalized abortion. And when we were there, where we had our conference there, the abortion-related deaths in Ethiopia were as less than 10% of the death of women. Because women in Ethiopia, girls in Ethiopia, freely go to hospitals and have abortion. In fact, for the first time, we were taken to abortion clinics to see what happens there, because it's legal. No one hides. In Uganda, where I come from, we call them back street abortions.
yes.
When I was in a university, I used to teach in a school where girls would abort. And I remember cases of girls who died because of abortion. Now, taking it back to the doctor, what I wanted to clear from Lynda is that no one allows you to abort in Uganda because you have been raped, because there is incest. No one allows you. It means you are going to have that baby. Now, going back to the doctor and going back to the policy analyst, and my concern is that, having said all this, what is being done in terms of creating awareness that there are these dangers, that these laws must change, that these biases, for example, the bias people have from religious practices where people say you have to produce as many children as you want because God told us to multiply. Now, if you tell who never went to school, you are most likely going to say, why should I stop having babies? It's a God-given right. If you tell a woman, look, if you are financially struggling, stop having children, she's going to say, God will provide. Now, I take it back to you as I'll think of you, beginning with Washila. What is being done in terms of attitude change? Are there efforts that you know as policy analysts that are geared towards changing the mental faculty of our people to think better when it comes to reproductive health? Washila.
Wachira, did you hear me? We can't hear you. Wachira, do you hear me? The microphone may be on your side. Lynda, do you hear me?
I can hear you, yes. I think maybe his mic is off or muted.
Your phone should be off. Your mic is off.
I think his microphone is off.
Wachira, your mic is off. As the organized
You have
Wachira.
no sounds.
Okay.
There we
If
go.
I can start by answering, I think it was Lynda's question. It was Lynda's question first, where she asked that, where really do we define this, or how do we define this skilled personnel who can carry out the safe abortions?
Yes.
Yeah? Because even a surgeon can perform an abortion. Yeah, but I think in Kenya here, the constitution clearly outlines the relevant people. If you meet the requirements, for example, if for example you are an ENT practitioner, you're not really skilled or qualified to perform an abortion. It will still be considered as unskilled abortion. Yeah. Apart from that, and also she also had asked the second question on the issue of rape, on the question of rape. Where does the law really draw the distinction? For example, if we have, for example, rape by a relative, or even the rape that goes on inside the marriage. Yeah. Even in Kenya, we have the same problem. The law doesn't clearly stipulate, for example, if it's one kind of rape, that this one has some sort of weight than the other one. It doesn't give a clear definition or a clear distinction. However, rape has been a hot topic on whether, for example, abortions can actually qualify to be done. Personally, I haven't come across where such cases go on, that legal abortions going on in the name of rape. Maybe if they go on, they are sort of clandestine abortions. But right now, we also have some NGOs that help in raising awareness. They also help to, let's say, we can say to give the safe kind of abortions, the medical ones, yeah, the ones that still go hand in hand with the law. We have the Mary Stopes that actually helps a lot of individuals who are affected by this issue. So if we had many NGOs coming into practice, because the law doesn't really give clear distinctions or stuff like that, we may have many players coming along into the field. We have the Mary Stopes and other NGOs can also come in, and I think the normal citizen will benefit from this. So that I don't think it's really right if we have to let's say stick ourselves by the government policies. Yet we can actually be proactive and create our own, and not really necessarily rely on the government. Yeah. And also on Kato's question, for example, where does the country stand on the issue of abortion and all that, and the sacred, and we can talk about how it is sacred in Kenya, for example. It's actually a fact that majority of the country is actually religious. In as much as we don't really have a religious state, we don't have state religion in Kenya, but the fact that we have many citizens being religious, you may find that the issue of safe abortions or even women's rights will be shunned upon by the community as a whole. In as much as it's not there by law that we should all be religious, it doesn't say that Kenya is a secular state. However, we have a majority religious individuals. So this one will sort of create a stigma around the issue. Even when I think it was Morris that talked about the Kihika bill, which was a hot debate back in 2019. I think it was in 2019. Yeah. So part of the reason why it was shot down, it was actually because of the religious majority. Because we understand how it goes, the sacredity of life, how life is sacred. You can't really terminate a pregnancy like that, and yet it's human and all that stuff. But when we come to activate our let's say critical thinking powers, if I can say that in quotes, or the fact that most of us are humanists, I think we don't really have to tie ourselves to such dogmas. We should just apply reason. For example, if you're forcing someone to carry a product of rape, even maybe incestuous rape, it could take a psychological toll on the mother herself. So I think we should be encouraged more to be critical thinking more about it, so that we can have realistic solutions to realistic problems. I think that's my take on that. Yeah, but thank you.
That is very important. We have 6 minutes to the end of the show. Mr. Wachila, do you hear me?
Yes.
Thank you so much. As we wind up, please, take home from this kind of conversation. Having had everything, we would like you to give us those parting shots, very critical things we should take away from you tonight, and we should be able to have you in the next show on the same topic in the nearby future. Wachila, back to you.
Thank you very much. I hope I'm audible now.
Yes, we can hear you.
Okay. So the bottom line here, we are seeing two main issues: the superstition and religious side, and the economic side. Economic side go with the political side, but I think the religion or the superstition or the tradition side is coming out as more pronounced, and especially the issues you're talking about, where men don't even seek, especially in this region. You're right. Men rarely go to hospital, and if you see a man going to hospital, they are really sick. They are like, it's really something very serious, and it also comes from the traditions where there's a lot of like toxic masculinity sort of, and then there is also the traditional side, the religious side, where a man is supposed to be a man, the macho, you're not supposed to just go hospital for small headaches, small diseases. You're supposed to be this big, and it's something that is culturally in the long, and this attitude permeates among the whole sectors, even among some health professionals. I was surprised to realize that young men who are seeking vasectomy in most hospitals in Kenya are taught to undergo psychological tests. And I was like, what's the purpose? What's the purpose of that? Like, so what happens if you fail the test? Ideally, are they saying that if you fail a psychological test, then you have to have children? So and it's a really ridiculous thing, because it's a ridiculous policies coming from these some of these institutions. I thought in an ideal situation, people who want to have kids are the one who should undergo a psychological test their ability to raise kids. But these are policies. These are some of the policies that are not driven by data. They're not well informed. They are not objective. And this is what happens when religion and superstitions permeate society and the government. Decisions are not based on data. They're not objective decisions. They are based on how I feel, how I would want to. There was also a time the late President Magufuli of Tanzania said all girls who get pregnant should not be allowed back to school. I think that was like 1 year before he died. He said they should never be allowed back to school. And he was very serious about that law. And he quoted his Catholic faith as the justification for that. So it tells you that the extent to which religion can really be destructive when it's used as the basis for which people make, and that's why we have to keep pushing for secularism, whereby people practice their religion in private, but in public policy, in public life, we have to be guided purely by data. We have to be guided by data and nothing else. Practice your religion, practice your superstitions. It's okay. You have to guarantee you the right to that. But public policies must always be based on data. The government and the NGOs have a big role to play in this one, as I look at it. Number one is the government has to avail data, because as much as most NGOs don't have the capability to collect data, because collecting data is very expensive. So it's the role of the government to ensure that the data and as well as the legal framework is there, and sometimes also to avail the resources. That are needed for this. But the NGOs have to keep pushing for the policy change. I'm glad of the space that the civil society enjoy in Kenya. They have really led to a lot of policy changes in so many areas, not just in the healthcare. So it's a small space, but I think the very fact that the civil societies are vibrant and they are very and also the new constitution has made it. It's very consultative when coming to policy. It's now, most laws have been passed in parliament, have been declared unconstitutional just because they did not have what we call a public participation. It's a requirement for every law to go through public participation, which includes the civil service, the civil society. And finally, so the way forward, first of all, I have to say that the right to bodily autonomy and integrity are recognized in the Universal Declaration of Human Rights. But nonetheless, women are still being denied this right. In some cases, we have very retrogressive systems and laws which are to blame for this, as well as traditions and sometimes some modern norms which exist. So, as I said in the beginning, we have a national policy. We have a policy on reproductive paper. I just outlined 4 things that it falls short of, and you can see the way the policy was framed. It has a lot of indirect superstition and religious influence. These are people who are not willing to name the word abortion. They're not willing to name things like contraceptive, fertility. There is a lot of superstition rather than being data driven. So that's why you find that it prioritizes things like abstinence. That is like a national government policy. Its number 1 priority is abstinence, and this is from the Ministry of Health. Then it raises the age of consent to 21 and says that all those held the productive health services need parental consent. So the parent, as an 18-year-old, as a 20-year-old, as a 21-year-old, you cannot make decisions about your body. It has to be. And as we know, the older generation is very conservative in this country. So those are some of the areas that it doesn't. The whole law does not recognize commercial sex workers who are very high risk. Does not recognize any LGBT thing, and people living with drugs, people who are drug takers, and those are very high risk segment of the society. You'd expect a data-driven policy that this will be priority target for them, but because of the tradition and the influence, that's what they saw best. So the enforcement of parental consent in the reproductive health policy puts adolescents under the age of 18 at a great loss. This means that the view of adolescents regarding their sexual and reproductive health are not valid in the eyes of the government. Denying adolescents crucial health services like contraceptions will not only lead to more teenage pregnancies, but it will expose them to gender-based violence, which in turn might result in increase in HIV and all those other consequences. So the other thing that the final thing that the religious or the tradition are pushed so much again is education, reproductive education and sex education in Kenya. It's another area that they have really, especially the Catholic Church. I have to point them out. They have really fought this one outrightly. The Catholic Church has been more pronounced on sex education and contraceptive. They have really fought, and they are very powerful in this country. So they have really pushed against that. Even if you look at whatever is being called sex education is a joke. Is a joke, especially being offered by government. So for me, the person's ability to choose what they do with their body is critical for their ability to live a fulfilling life with dignity and to be productive member of the society. When it should be obvious that the enjoyment of body autonomy and body integrity is critical to the realization of full range of human rights, should therefore be guaranteed for everybody. But the sad reality is that many women and girls' body autonomy and body integrity remain quite elusive. Because bodily integrity and autonomy influence so many aspects of health, as well as the decent, dignified life, progress in realizing them will lead not just to achieving sexual and reproductive health and the sustainable development goal of on gender equality, but many more goals as well. And to conclude, I say I believe the rights to bodily autonomy and integrity are core principles that can mobilize and unite diverse effort and address the social and structural determinants of health. So I will stop there. Thank you very much. It was very engaging, very educating, very informative, and one of the things I also forgot to say is about we have also a lot of we have a lot of work. We have a lot of health infrastructure, the general infrastructure. But the worker, in terms of the workers, we have an excess in terms of labor force because the government system doesn't work so well in terms of providing healthcare. So what is happening? There is a lot of labor flight, especially to UK. I think now every Kenyan nurse want to either to go to UK, to Australia, or to Canada, and in the long run, I think in the next 1 or 2 years, is going to be negatively felt because now there won't be anybody to do it here because first of all they are underpaid, they don't live in a good condition, so they will serve Kenyans as the last resort, not as their first place of as their first choice of providing healthcare. It's also a big challenge that we have to focus. But thank you very much. It was very enjoying.
That was wonderful, Mr. Wachila. It was great having you. In fact, you have educated us on so many important things. As we wait for a conclusion from Lynda, we'll be winding up the show. Let us have our medic to give us your parting shots, the medic.
Thank you very much, Kato. My parting shot is that I would like also, before I start with mine, I will very much agree with Maurice's sentiments on this. I think the policies should be evidence-based. You know, in Kenya, there was a time in high school, sometimes back, where there was a belief that they put paraffin in children's diet. And the belief was that, you know, paraffin really lowers the libido, something of the sort. They lowers the libido in boarding schools. But funny enough, there was no studies that seemed to back that up. But the fact that it was rampant in most Kenyan high schools, it really shows that there was a problem, that some of the policies don't really have any logical backing or any evidence around it. So I think I would really much like to agree with these sentiments. Apart from that, the only way I think we can really improve the reproductive health in itself, and even the health rights of all the key players in our societies, it's number one, I think we should have it should be a collaboratory effort. We have the government, we have the NGOs, and even we have us ourselves, and even the let's say the practitioners, the healthcare practitioners. So as long as it's inclusive of everyone, I think only then we can realize that some of us are not really getting the equal benefits, and we can work on that. Some of us are not really getting the right amount of for example, the healthcare, the justice. There's really a great disparity in the society. So once we come together and identify that, we can really sort of close the gaps that are really existing between us and getting the adequate amount or the good amount of reproductive health that's around. Also, apart from that, I think we should also, if, for example, the government should be willing to give some sort of improvement on the research being done around the area, because apart from the statistics we still have, there's still deficiency in some data. Some research needs to be done. There's a lot that's really not really known about the world, or how the dynamics between the health-seeking behavior and specifically on matters reproductive health. So if for example research is done, maybe the NGOs can be encouraged, maybe the government can chip in with the grants and funds and all that. I think once we get the knowledge, we can be able to work around it and identify the problem and give adequate solutions on the problems we face. I think that's all I can say for now. Yeah, thank you
So much, Dr. It has been great having the two of you on the show, Mr. Wachila, Mr. Adrian. I think you have educated us as well as our audience. I will look forward to having you more different topics. Being secular humanists, I know you have a wealth of knowledge on a number of topics, and I will beg you to always consider our request to join us in a different kind of discussion in the future. Lynda, my co-host, you are the one concluding this show. I'm very happy we had this show today. Lynda, yes, you are to everyone and concluding the show.
It's been wonderful having you both on here. It's been wonderful having you both. I think what's also really heartening is to know that there are so many people that are battling with the same things across Africa. Every single African country has a huge growing number of people that are leaving religion behind. There are so many secular Africans. It's heartwarming to see it. I've seen a huge growth in this in the last 3 years, and especially in countries that you would never imagine it, like our very Islamic states in West Africa and in Nigeria. There are thousands upon thousands of people leading double lives, or that we are in every country in Africa. Well, there's 12 to 14 that I work with, and with humanists in those countries. Each and every single one of those have huge numbers of people with secular outlooks that have left religion behind, that are all fighting in their own ways for secular education, secular healthcare, secular governments. And I just think that it's amazing that, I know often you feel maybe that you are on your own in your fights with things. We are all feeling it. We are all reaching the stage where we are realizing that we have to get religion out of our governments and our education systems, and we have to be able to embrace all religions and to come up with policies, especially in important things like education and healthcare, that are for the good of all people and not just certain groups of people, because it's bias. You're putting bias if you're basing policies on religion, or say on the Catholic Church. So I just want to thank you. Like Kato said, I always talk about, I have the greatest respect for teachers and for healthcare workers here. It's our healthcare workers that are saving lives, not any God. You know, it's science and people's skills that are actually saving lives and giving people a better quality of life here. No prayers are doing that. So I really want to thank you both. And I know that you're up against a lot, and it must be very frustrating for you having to, you know the changes that need to be made, but it's very slow coming. Is that take heart in knowing that there are people in other African countries that feel the same as you do, and that are all working in their own ways to create a secular country and a one day, hopefully, secular Africa. So it's really important for us to have these discussions, because this show alone goes out. I think we have viewers in about, I don't know, 18 or 23 of our African countries. People watch. They don't always watch live. It's mostly after the show because of data restrictions and that. So that this message that's going out today, that Kenya has spoken to us about, there are so many other countries out there that will relate to what you've said. And this encourages open dialogue, and it also encourages us as Africans to realize that we're not individual countries. We are all one continent, and that, our neighbors and people across the continent aren't foreigners. They are our neighbors, and we are all dealing with the same issues. That collectively, as African people, I do believe that if we work more together, we are able to resolve those problems, because we all face the same issues. So thank you very, very much for coming on the show today. It's been great meeting you both. Thanks, Kato.
Thank you so much, Lynda, for that parting shot. Thank you so much for coming, Wachila and Maurice Wachila and Eugene Medek. Thank you so much for all of us today.
Great. Thank you so much.